So Dr. Plattner is an expert in maternal fetal medicine, coming from the Department of OBGYN. She's going to talk to us today about pregnancy and contraception, an important topic. Thanks so much for being here.
Thank you for having me.
And lunch is next.
Good morning. I know everyone must be getting hungry and antsy. I have to say thank you for inviting me to speak today. So I'm a maternal fetal medicine specialist. I did my residency here at Emory, and then I left for fellowship, and I came back as faculty several years ago. I have no financial disclosures report, but these slides were adapted from my colleague, Dr. Carolyn Duty, who gave a similar lecture several years ago. So some of her slides are incorporated here as well. So just want to make sure that I give her credit. So I was asked to come talk to you guys and provide you with a little bit of basic information to talk more about pregnancy and how we manage pregnancy, as well as contraception in patients who have SCAD and FMD. And I recognize that not all pregnant patients are women. For the purposes of this talk, please just excuse my language of, so like the word I will use is women, but understanding that birthing persons are included in this. So I'll start by telling you a little bit more about what I do as an MFM specialist, and then I'll give you a brief overview of any key physiological changes that can occur. I don't want to get too bogged down in those details because I think sometimes we can get into the weeds there, but to really give you an idea of why this can pose a unique set of risks for women with pre-existing cardiac conditions. And then we'll talk about the importance of pregnancy planning and contraception in women with underlying medical conditions, and talk about what questions you should be asking at these appointments. And then we'll talk briefly about general management of pregnancy in women with both SCAD and FMD. We'll have a little bit of time for questions at the end if you have them. So a maternal fetal medicine specialist is a subspecialty of OBGYN, like Dr. Wells mentioned, which means that we go through a 4-year residency program followed by 3 years of fellowship. And during fellowship, we focus on ultrasound skills to gain an understanding of fetal physiology and anatomy, and then additional training in specific medical, obstetric, fetal, and genetic complications of pregnancy. So all this extra training helps us to be better prepared to take care of women who have chronic diseases, who get pregnant, or pregnant women who get acutely ill during their pregnancy. This diagram is from the Society of Maternal Fetal Medicine, so we work in a variety of settings as well. Some of us do primarily consultations, co-management, transfer of care, inpatient, outpatient, etc. So all of that makes us uniquely prepared to help complicated pregnancies. So we're going to talk first about why pregnancy poses these unique challenges for women with cardiac conditions, and specifically talking about FMD and SCAD. So you can see here from this picture that pregnancy does impact every organ system of the body, and the cardiovascular system is certainly no exception. So during pregnancy, we have increases in both the blood volume, or the amount of overall blood circulating in your body, as well as the heart rate. The mom's heart does start to enlarge during pregnancy, and this is normal. And it's also very normal for women to feel or experience palpitations during their pregnancy. Additionally, many women do develop some degree of anemia because while the production of red blood cells does increase during pregnancy, we also have an increase in the overall blood volume, and so it doesn't add up equally. So most women get some sort of anemia during pregnancy. All of these changes start as early as 4 weeks into the pregnancy, and they can continue for several months postpartum. Most of them are due to a hormone known as progesterone, which can cause a decrease in the peripheral vascular resistance, and then leads to a decrease in blood pressure. So many pregnant women may feel symptoms of dizziness or lightheadedness, especially early on in pregnancy. And many women who are on blood pressure medications coming into pregnancy no longer need them during pregnancy because their blood pressure does drop during the beginning of pregnancy. Now that's in the first and second trimester. So in order to account for this drop in blood pressure and help the body prepare for the blood loss at the time of the delivery, the blood volume also increases during the course of the pregnancy, and we think it almost doubles, reaching its peak at about 32 weeks of pregnancy, which is well into the third trimester. So that's the time when we usually start seeing our patients more frequently, talking to them about associated symptoms, lower extremity swelling, palpitations, shortness of breath. The challenge about all this is that many of these symptoms can be very normal symptoms in pregnancy, and so the key is trying to figure out what is normal and what is abnormal, and when do we need to escalate care. So really important that if you do have symptoms of those type in pregnancy, that you talk to your doctor about them so they can help guide you. Then in order to account for that increase in blood volume, the heart has to keep the blood flowing and pumping it out to the rest of the body. So the heart starts to work harder and pumps faster. So it's very normal for a woman's heart rate to be about 15 to 20 beats higher per minute than their normal heart rate. So resting tachycardia is considered to be normal in pregnancy. And then we have an increase in the stroke volume. So the amount of blood that the heart is pushing out, as well as the increased heart rate. And both of those together leads to an increase in what we call cardiac output. So as the output increases, the heart has to work harder to keep up with the continuing demands of maintaining the pregnancy. And so I tell my patients that really pregnancy is a stress test. And it's an ongoing stress test that doesn't end after 30 minutes, but continues for 40 weeks of pregnancy. So it's really a lot of work. So you need to be at a baseline, relatively good state of health when you enter pregnancy. And then once you get to the end of pregnancy, you still have to go through the most challenging part, which is the actual process of labor and delivery. And this process and the contractions increase the cardiac output by over 51% above the baseline, which is a huge amount of volume for the heart to deal with. And then during the pushing, or what we call the second stage of labor, you often do something called a Valsalva maneuver, which can cause a drop in blood pressure and then decrease the overall cardiac output because of the decrease in blood coming back to the heart. And then once the baby and the placenta have delivered, we have a subsequent increase in cardiac output by about 80%. And this is secondary to all the autotransfusion that occurs due to increased blood flow to the uterus and decreased pressure on what we call the vena cava, or the blood that's coming back into the heart. This final increase in cardiac output can actually take several weeks and even months for a woman's body to go back to baseline. And as a result, the postpartum period can be a time that we consider really high risk for women who have pre-existing cardiac diseases. So how do we best prepare for this? We know that SCAD and FMD primarily affect the blood vessels, and although this doesn't directly is not directly the heart, they can be affected in a very similar way. As there's a lot more stress on the associated vessels with all this change in blood volume, and can lead to adverse events such as a dissection of the vessel, acute constriction of the vessels, or even a stroke. So pregnancy is a very uniquely challenging time for women, but especially for high-risk moms who have underlying cardiac conditions. But there's one thing that we can do to improve outcomes for pregnancy, and many women in Georgia are not able to do this. Does anyone have any ideas of what that might be? So ideally, we want to plan a pregnancy. This is a slide taken from the Guttmacher Institute, and you can see the bottom right corner here is the Southeast, and here's Georgia here. And so we are notoriously not great at planning pregnancy. So we have one of the highest unintended pregnancy rates in the country. In an ideal world, we as OBGYNs would try to make sure that everyone has a planned and desired pregnancy at the time that they want it, but this is definitely more critical in women who have underlying medical conditions. So next, we're going to talk a little bit more about pregnancy planning and contraception for when pregnancy is desired, and then pregnancy planning for when pregnancy is desired. So many of you may be aware that hormones such as estrogen can increase the risk of cardiac events in women who have pre-existing SCAD, FMD, and other cardiac diseases. So it's generally recommended that we do avoid estrogen-containing methods of contraception. Fortunately, we have plenty of options that are either hormone-free or progesterone-only options that don't actually carry these same associated risks. And there's two really great resources that I always refer my patients to. The first is the CDC medical eligibility criteria for contraceptive use, and you can only see the top half of it here, but this is a really long and detailed chart that goes over various medical conditions and which methods of birth control or contraception are safest. And then at the bottom here, you can see bedsider.org, which is also a very patient-friendly website for information that can help determine which method of contraception is best for you based on side effects, overall effectiveness, long-term fertility goals. Now, this CDC chart does not specifically include SCAD and FMD, but you can kind of adapt it to look at other medical disorders that also recommend avoiding estrogen-containing methods of contraception. Most important is that you find a method that you feel comfortable with using, because if you don't, then you're less likely to actually use the method that you've chosen. And this is something that you can talk to your OBGYN about, you can talk to your primary care provider about, and then there's, of course, the option of male sterilization or vasectomy, which is very effective as well, but is also relatively permanent. So you can see here in this graphic, this is taken from bedsider.org. So the top row are the methods that work most effectively, and it goes down with relative effectiveness here. And the good thing about this top row is that all of these options are either progesterone only, such as the Nexplanon, an IUD, a copper IUD, which is no hormones at all, or sterilization. The only thing about these options is that they all require a provider who is comfortable and trained in placing them or performing a procedure to place them. So you can talk to your primary care doctor about it. Some primary care doctors may have experience in placing Nexplanons, but I think more commonly they would refer you to someone for this. But there are many of us who are trained and able to do that. Now, without reliable contraception, about 90% of reproductive age females will get pregnant within 1 year. And although having a chronic condition such as SCAD or FMD can make pregnancy a more dangerous situation, they don't actually change a person's fertility or reproductive potential. So it's really important to talk to your doctor because most women don't intend to get pregnant when they do. And we really want to make sure that for any woman who has an associated high-risk medical condition that we're planning and really thinking about all the risks to pregnancy. So what if you're at a point in your life when you do decide that you do want to get pregnant? This is a perfect time to set up what we call a preconception visit. There are general OBGYNs who can do this, and they can help by making sure you're up to date on all current vaccinations, that you've undergone genetic carrier screening, if there's a genetic component associated with your FMD at all, that we can screen for that as well. And then making sure that you're taking a prenatal vitamin. All women of reproductive age should be taking a prenatal vitamin. If you're considering conception, we really want you taking that for at least 3 months prior to conception. And then you can also schedule a preconception visit with a maternal fetal medicine specialist. And that's where we can actually sit down and go over your specific condition and your specific risks in more detail. Oftentimes your OBGYN may recommend this for you. Other times patients seek us out on their own. But either way, there's lots of good questions to ask at this time. So first off, what is the ideal time to get pregnant for you? For example, did you just recently have a SCAD event? Has it been several years and you've been very stable on your current medication regimen? The answer always depends on your baseline state of health. Ideally, we want to delay pregnancy until all of your medical comorbidities have been optimized. And then we also want to review any current medications that you may be taking. There are certain medications that should be stopped prior to your pregnancy, and if you're taking one of those, then we would recommend trying to stabilize you on a different medication prior to conception that may have better safety data in pregnancy. Although what I will tell you is that the vast majority of medications are safe in pregnancy from what we know, but we always want to sit down and weigh the risks and benefits. And so I always tell my patients, we can't actually have a healthy baby if we don't have a healthy mom. So we need to make sure that you never completely stop your medications. If you get a positive pregnancy test, you always want to call your provider and figure out a good plan of care. Many commonly used medications are continued in pregnancy. We use aspirin very commonly and recommend it for many of our patients, even without chronic diseases. Beta blockers are used, calcium channel blockers, and anticoagulation such as heparin or Lovenox are very commonly safely used in pregnancy. And then the last thing we want to do is make sure that you're up to date on any routine imaging surveillance that is indicated prior to pregnancy so that if any new issues are found or arise, it can be appropriately treated or addressed before conception. And then the next big question, and this especially comes up in a place like Georgia, is where is it safe to have a pregnancy? We have a lot of rural areas here in Georgia where there are not OB providers, let alone an MFM provider, who can work with a multidisciplinary team to provide you with safe care. So this is a really big concern here because of the possibility of a major cardiac event. For women with pre-existing cardiac diseases, we know that it's really critical that they deliver in a tertiary care center at a hospital that has OB, MFM, and cardiac services, but also a cardiac ICU available in cases of emergency. Here at Emory, we deliver most of our patients at Emory Midtown for these exact reasons. Because we have a very strong multidisciplinary team. We have OB anesthesia, we have cardiac anesthesia, we have interventional cardiology, general cardiology, OBGYN, maternal fetal medicine, and our OBGYNs and anesthesiologists are in-house 24 hours a day. There are not a lot of hospitals that offer all these services, so it is possible that you may have to travel for some of your care. We have patients who come to us from all over Georgia, as well as Tennessee, South Carolina, Florida, and even Alabama. And then lastly, what is your specific risk of an adverse outcome in pregnancy? Because we know that there's only so much we can do to really optimize pregnancy, and even after all of that, there's still going to be some level of residual risk present. So before I go into a little bit more detail on those risks, I do have to mention that in Georgia, we have really high risks of maternal mortality. And if you look at the underlying causes of this, it's really strongly driven by cardiac disease in pregnancy. So the highest cause of death is hemorrhage. And then if you look at this over here, the combination of cardiomyopathy and cardiovascular conditions really takes the lead when you start to put that together. So a lot of my personal research is on severe maternal morbidity and the underlying causes of that, and we focus a lot on the cardiac causes of severe maternal morbidity. It's not specifically focused on SCAD and FMD, but these kind of fall into that category. So we want to make sure that we're prepared and getting good care. Most cardiologists and maternal fetal medicine providers use what we call the WHO classification to determine women's risk of adverse pregnancy outcomes based on their underlying cardiac disease. And so this system basically divides cardiac conditions into 4 major risk categories, with the first one, category 1, considered to be very, very limited increased risk. So maybe no increased risk of maternal mortality and either none or mild increased risk of morbidity. And then we have all the way up to category 4, which is an extremely high risk of maternal mortality or severe maternal morbidity. And in these patients, pregnancy is actually contraindicated. If those patients come to us already pregnant, we do talk about termination because it is so dangerous for those moms. The challenge that we have is that we can't clearly place SCAD or FMD into any of these categories. A lot of them have to do with congenital heart disease at baseline or other genetic abnormalities like Marfan syndrome, or Ehlers-Danlos, things like that. So very little is known. So what are the specific risks of SCAD and FMD in pregnancy? So this is from a paper that came out from the American Heart Association in 2018. And what they talk about is their concerns for possible recurrent SCAD in pregnancy on re-exposure to the hormonal, physical, and emotionally stressful conditions that present during pregnancy, and especially the postpartum period, as well as the current lack of secondary prevention strategies. Many clinicians really recommend against pregnancy in women after SCAD, but there's really not good data to support this. And that's where we have this potential challenge for us as providers. So at the time that this was published in 2018, they reviewed a study that looked at 8 patients for a total of 3 years of follow-up. And in those patients, 1 patient had a recurrent SCAD event during pregnancy, and it was fairly catastrophic. And we know that SCAD during pregnancy can be more severe than outside of pregnancy. And so this really requires very careful counseling for each individual patient based on their risks and their fertility desires. Now, in 2020, there was another study that was published in JAMA, and this looked at the actual risk of recurrent SCAD during pregnancy as well. They enrolled 636 women from the Mayo Clinic SCAD registry, and all these women were of reproductive age. And then out of those women, there was a total of 32 pregnancies after SCAD. So, and then a total of 92 cases of recurrent SCAD. And they looked at women from both groups, those who did get pregnant and those who didn't get pregnant. And what they found is that there was actually no significant difference in the group of women exposed to pregnancy compared to those without the pregnancy. So, what I concluded after reading this is that although this is definitely a really small sample size, I agree with the authors of the study that this is very reassuring, but we still need to be very cautious and aware of the various hemodynamic changes that occur and how this can lead to a much more severe presentation in pregnancy. The other things that we worry about, and these are very standard in our offices, are the risks associated with chronic hypertension. So, preeclampsia is a disorder where women get worsening high blood pressure or high blood pressure during pregnancy, and then associated protein in their urine, and then end organ damage to their kidneys, their livers, and their platelets, as well as like cerebral edema and swelling in their brain. So it can be really catastrophic, as well as growth restriction. And as a result of those two things, oftentimes results in what we call an iatrogenic preterm delivery. So something that we end up making a recommendation to deliver them early as a result of this. Preeclampsia is especially risky for any woman who has abnormal vasculature because this causes the blood vessels to become fragile and can lead to an increased risk of strokes, even at a blood pressure that this may not happen to outside of pregnancy. So a lower blood pressure. So our cutoff when we consider preeclampsia to be severe is 160 over 110, and we treat blood pressures at that level. Whereas if you went to the emergency room with those blood pressures, they would be very unlikely to acutely treat you with those blood pressures. Unfortunately, the only way to treat preeclampsia is by delivery. And so when this happens early on in pregnancy, it takes a lot of thought, counseling, and shared decision-making to decide when to deliver, because sometimes these babies end up being born very early to save moms. And then, of course, the risks of a major cardiac event, such as a dissection, stroke, or a heart attack. There's very limited literature on this, fortunately, because the overall risk is low, but we do know it can happen. So how do we manage women with SCAD or FMD once pregnancy is confirmed? This is obviously going to be different for every patient, depending on what their presenting factors are, what their medications are, and what their other comorbidities are, but this is somewhat of an overview. In the first trimester, it's really important to make sure that we have established a functional status for your cardiac functional status, establishing care with a cardiologist who works closely with an OB and an MFM provider, because we know that multidisciplinary care can really help improve outcomes. Similar to what you would do at a preconception visit, we sit down, review all your medications. We would get baseline preeclampsia labs, which was really looking at your kidney function, your liver function, and how much protein at baseline is in your urine. We would recommend initiating baby aspirin if you're not already taking it, and then undergoing routine genetic screening and established dating for your pregnancy. In the second trimester, we recommend a baseline anatomy ultrasound, and then for most women who have any chronic medical disease, we do recommend serial growth ultrasounds where we check in on moms and babies on a monthly basis. And then when we get to the third trimester, we want to make sure that you've been seeing your cardiologist throughout the pregnancy. Most women will end up needing a repeat echo or some sort of repeat imaging in the third trimester. And then this is when we start to think about delivery planning, scheduling a consult with anesthesia, and determining mode of delivery. So the two most important things when we think about delivery planning are going to be timing of delivery and then also how are we going to deliver. So we generally recommend delivery by 39 weeks, which is 1 week prior to your actual due date, because this has been shown to be associated with a decreased risk of preeclampsia and improved outcomes for babies as well as moms. However, for patients who have pre-existing high blood pressure or are taking medications or do have that diagnosis of preeclampsia, we may recommend delivery even earlier. 37 weeks is what we consider full term, so this is a very reasonable goal if everything in the pregnancy is going as expected. And then when we think about how to deliver, this is another area where we really don't have a ton of data on this. Most people seem to think that a vaginal delivery is safe. We know at a baseline, vaginal deliveries are the safest things for moms and babies because it decreases like the surgical risk to mom and decreases actually maternal morbidity for mom, and also improves outcomes for babies. So that is always our goal. oftentimes we offer patients, and this is generally recommended for patients with SCAD and FMD, is what we call an assisted second stage of delivery, meaning that we help when the baby is coming out through pushing, we help with either forceps or a vacuum. And this tends to have really good outcomes for our patients. Sometimes we may recommend a C-section if we start to take into account moms who have worsening heart failure, really can't bear down or do that Valsalva maneuver at all, or have associated symptoms or syndromes such as Marfan's or Ehlers-Danlos syndrome. Some considerations that we think about are early epidural placement, making sure that we're treating high blood pressures and women are in the correct position to optimize blood pressure control. And then lastly, during the postpartum period, we really want to make sure there's a plan in place for very close monitoring with the OB and the cardiologist to make sure that if symptoms do arise or complications arise, that there's a clear plan to manage those. So I hope that this has given you some insight into what pregnancy and contraceptive options are available for women with SCAD and FMD, and hopefully can help guide you through your family planning journey. Most importantly, I think you really want to make sure you have a good team who has experience with this and has the facility and the colleagues to work together to provide multidisciplinary care. So I'm happy to take questions.